A very warm welcome to everybody. Myself, Dr. Rajiba Lochan Samal, currently working as Associate Professor Anesthesia in the Department of Anesthesia, IMS Home Hospital. I would like to express my gratitude towards the organizers of 47th WIMS Anesthesia Alumni Academics, Dr. Srinivas, Dr. Balavaskar, Dr. Parimula, and Dr. Josna for inviting me to this webinar. The topic I am going to talk about is the etiology and preventive aspect of postoperative sepsis. Uh, Coming to the infection severity continuum, sepsis start with infection. Infection from a localized tissue enter the cell blood causing bacteremia, which can lead to sepsis, and this can be complicated by septic shock, leading to multi-organ dysfunction and death. SIRS and severe sepsis no longer included in this continuum. Coming to few simple definition, infection, bacteria, they are all different from sepsis. Infection, invasion of normal sterile tissue by organism resulting in infectious pathology. Infection, bacteremia, presence of viable bacteria in the blood. Multi-organ dysfunction, most progressively organ dysfunction in an acutely ill patient such that homeostasis cannot be maintained without intervention. Organ dysfunction can be primary, can be secondary. Organ dysfunction occurs early and is directly attributable to the insult itself is the primary organ dysfunction. Organ failure that is not direct response to the insult itself but is a consequences of host response is a secondary organ dysfunction. Coming to the definition of sepsis, third international consensus definition of sepsis, which is called sepsis 3, is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. When sepsis occurs after surgical procedure or during the post-operative hospital stay, it is typically called post-operative or surgical sepsis. Most of the journal they mentions first 30 days of post-operative period if sepsis happens, called post-operative sepsis. Coming to the old definition of sepsis or diagnosis, two or more systemic inflammatory response syndrome criteria when coupled with suspicion of infection is called sepsis. In this criteria, there are four criteria there: body temperature, heart rate, tachypnea, and WBC count. Body temperature more than 30 degrees Celsius, less than 36, heart rate more than 90 beats per minute, tachypnea, which is manifested by the respiratory rate more than 20 breaths per minute, or carbon dioxide partial pressure less than 30 white blood cell count more than 12,000 or less than 4,000, or presence of more than 10% of immature neutrophils. Any two or more criteria can lead to diagnosis of sepsis. Coming to the new definition according to sepsis 3, sepsis is now defined as acute increase in SOFA score of 2 or more from the baseline in a patient with suspected infection. In SOFA criteria, they have included 6 organ systems like respiration, coagulation, liver function, and cardiovascular, neurology, and renal. In respiratory system, it is the hypoxic index. According to the severity of hypoxic index, the score is severity score is given. According to in the coagulation system, according to the number of platelet count in liver function, according to the bilirubin amount, and cardiovascular system according to the severity of hypertension. Neurology system according to the GCS, and renal system according to creatinine or urine output. The SOFA score criteria is given. As SOFA score criteria, there are lots of objective parameter laboratory tests, so it takes time for non-ICU setting for quick assessment of patient. They have developed quick SOFA score, which involve only 3 criteria like respiratory rate more than 22 per minute, change in mental status, or systolic blood pressure less than 100 ml. Two or more criteria with suspected infection it, can lead to diagnosis of sepsis. Here we have to remember that though these are the definition of sepsis, but they are never intended for starting the treatment or treatment failure. They are intended to predict the prognostic factor, so mortality. If the score is high, there is high chance of mortality. They are all designed for risk stratification of the patient. Coming to septic shock, when sepsis defines septic shock more specifically as sepsis, in addition to shock that require start of vasopressor to maintain mean arterial pressure more than 65 mmHg or greater, and serum lactate value greater than 2 millimole per liter following adequate fluid resuscitation. Coming to incidence, across the globe, the proportion of posterior sepsis varied from 2.9% to 30% in various studies. Multi-center studies are lacking in India to actually know the burden. Posterior sepsis epidemiology data from India has been mostly accounted from the retrospective studies, single center studies with small sample size. So it vary according to the patient, according to the nature of surgery. Coming to the risk factor of sepsis, risk factor have divided into patient-related risk factor and surgery-related risk. In patient where the male gender that is increases sepsis, old age with increasing age, chances of sepsis increases. Most of the all comorbidities increases chances of sepsis like hypertension, diabetes, all among these pre-existing heart failure, chronic kidney disease and anemia, their chances of sepsis are very high as their odds ratio is more 2.53. In chronic disease it is 3.6, and addiction in alcohol dependency and smoking there are also increased. So we have to remember that addiction like these kind of things are modifiable risk factor. We can modify before elective surgery so that there will be less chance of sepsis. And the surgery related expert is the emergency nature of surgery that is very high prone for post-operative sepsis. Perioperative blood transfusion also more chance. And inpatient hospital stay, it is more than 10 days. Hospital stay increases chance of sepsis because of there is more chance of acquiring hospital-acquired infection, which are multi-drug resistant bacteria, which can lead to more chance. And open surgery also increase chance of sepsis. According to type of surgery, like the GI surgery, like pancreatic surgery, esophageal surgery, and small bowel surgery, there is high chance of sepsis. Thyroid surgery, gynecological surgery, joint replacement surgery, and neurosurgery are the surgery associated with least chance of sepsis. Coming to pathophysiological sepsis, as sepsis start with a simple infection, that simple infection causing a bacteria to enter in the blood, causing bacteremia, that is leading to all coagulation abnormality and leaking of the blood vessel, leading to organ dysfunction and death. First, sepsis start with a interaction of a pathogen with the host. From the pathogen, the specific is the pathogen-associated molecular pattern, which interact with the damage-associated molecular pattern of the host, leading to dysregulated activation of complement system, coagulation system, leading to cytokine storm, leading to platelet dysfunction, and leading to all the pathogenesis of sepsis. It can be summarized here in the complete interest leading to cytokine, which lead to activation of inflammatory cell, leading to tissue factor activation, will lead to coagulation activation, fibrin formation, and consumption, DIC, consumption of platelet, which can lead to bleeding. Platelet activation and platelet aggregation lead to microvascular thrombosis, which leading to multi-organ dysfunction. Bleeding, multi-organ dysfunction both lead to death. Coming to the prevention of post-sepsis, as you know, there is high mortality in sepsis. Also, if sepsis happens, the financial, the hospital stay, or life loss, so its prevention is better than cure. So, prevention we have divided into preoperative measures, intraoperative measure, and postoperative measure. In the preoperative measure, surveillance of for healthcare associated infection. Early diagnosis of infection and treatment will prevent it going into the sepsis. Surgical site infections are the most common healthcare associated infection developing. So, the inspection of regular inspection of surgical site is very much important. Also, the infection the patient can acquire infection from three different sources. In the endogenous infection, it can happen from patient's own microflora which are present in the skin, gut, nasal passage, and it can be acquired from healthcare workers and also acquired from environmental sources like instruments, air, OT. Preoperative measures like environment in the by modifying proper maintaining environment in the operating room, decontamination of medical device will decrease the chance of sepsis. Preparation, proper preparation of surgical sites. Here I have to mention that like hair removal. So WHO specifically mentioned for hair removal you should use clippers and trimmers, not use razors because if you use razor there is abrasion of skin which will increase the chance of sepsis rather than decreasing it. Proper aseptic technique like hand alcohol using alcohol based hand rub and proper gown, gloves, all aseptic measure, hand washing, these simple things can lead to decreased chance of infection. Also, before improving the nutritional status and optimization of comorbid disease will decrease the chance of sepsis. In the intraoperative mirror, there are patient factors related to patient ensuring optimal body temperature. All of you know hypothermia can lead to decreased immunity, increase the more chance of infection. Also, hypothermia can decrease leads to coagulation abnormality, which can lead to blood clot or a presence at the surgical site can be act as a needles for infection. Oxygenation, WHO advice using hyperoxygenation can decrease the chance of death. If you are giving general anesthesia, so keeping the FRA to more than 80% will have a and FIO to more than 80% and continuing the oxygen therapy post-op period that will decrease the chance of sepsis. Maintaining euglycemic level will decrease chance of sepsis. Maintaining hydration, as you know, if you overhydrate, there will be leak from the anastomotic side, or if you underhydrate, there is chance of hypotension, which will complicate. So proper hydration by using goal-directed therapy will decrease the chance of sepsis. Also, maintaining adequate tissue perfusion will also decrease chance of sepsis. Coming to the surgical factor in the operative time, multiple studies have shown an independent association between prolonged operative time and risks of infection. Wound irrigation prophylactically, intraoperative wound irrigation is a key component of infection prevention. Uh, Intraoperative coming to systemic antibiotic prophylaxis, administration of systemic antibiotic 3 to 60 minutes before incision decreases the bacteremia load and also decreases chance of infection. Here, you have to remember that WHO advised against using antibiotic wound irrigation in a non-infected wound and antibiotic prophylaxis in the presence of drain. WHO advised against it. Also, systemic antibiotic prolongation in the post-op period, specifically more than 24 hours, are not advisable because it can lead to multi-drug resistance bag infection, which can increase the chance of sepsis. Also, operation theater tapping, the number of individuals and door opening in the operating room have been recognized as a major source of increased number of particles. Into post-operative measures like avoid liberal blood transfusion because transfusion associated with immunomodulation, also decreasing immunity. Also, unnecessary blood transfusion can lead to transfusion-related lung injury, which will leads to ARDS and also leads to sepsis. Wound dressing, WHO panel suggests not use advanced dressing over standard dressing on primarily closed surgical wounds for the purpose of preventing surgical site infection. Post-operative surgical antibiotic prophylaxis prolongation, WHO panel recommend against it. Also, early mobilization reduces the chances of sepsis by reducing the complication like deep brain thrombosis, urinary tract infection, also pulmonary infection, and pressure ulcer, which can be also so can be site for infection. Early removal of catheteroids, it will avoid the nosocomial infection, which can lead to sepsis. By improving nutritional status of the patient, also improves the immunity. Coming to final, as sepsis carries high mortality, so prevention is always better than care. Prevention of sepsis will lead to early discharge of patient, saves life, also decreases the financial burden of the patient. Thank you, everybody.